All right, everyone, I'm really excited about today's episode. I have on Dr. K. She is a high-risk OBGYN in maternal fetal medicine. I've been following her account for a while and just love the information that she provides. And I thought that it'd be really great to get an OB on here because I know that I share a lot, but I'm not a doctor. And so it's like, okay, Liz, you're a doula. How much do you really know about risk? How much do you really know about this thing? Because I have obviously not studied it to the extent that you have. So I'm so excited to be joined by you today. So thank you so much for taking time to come on the podcast.
Thank you very much, Liz, for inviting me. I'm excited to be a part of your podcast today.
Yeah, so I would love to start with you just telling us how you got into this. Like what made you want to be a high-risk OBGYN? And then what made you want to start using your platform to share information out there?
Thank you. So I honestly felt like going into obstetrics was something that God put on my heart to do kind of as a spiritual assignment. Some people feel like they have a calling to do different things. I feel like I was called to this. And when I was in residency, I was inspired by a maternal fetal medicine physician. Every time they talked about different concepts and they gave presentations, I was just extremely curious about the things that they had to say. The questions that I had the most about related to obstetrics rather than the gynecology aspect of my training. And I started to look into a little bit more of the understanding of what was maternal fetal medicine. And I felt like they actually were kind of the ultimate obstetricians. They were the people contributing to the research and to our understanding and pushing the envelope of what we should be doing, what we shouldn't be doing, and understanding the physiology. Like the more that I looked into it, I realized that those people that gave the guidelines and the foundation for our knowledge base are common day, real-time maternal fetal medicine physicians. And so I felt like that would be the end of my journey to become an obstetrician would be to go into maternal fetal medicine training. And so maternal fetal medicines are our name that we give ourselves or amongst ourselves, but sometimes the community calls us high-risk obstetricians or high-risk OBs. And then I was working on something with a partner, like a business partner, and we were trying to bring kind of a platform to the public. And I recognized that I needed to be a known entity for what we were trying to do, and nobody knew who I was. And so I started to get onto social media just so that there would be some awareness for the who I was and the credentials and the content and information that I had. And I just really came to like it. And at this point in time, the business endeavor that I was trying to do is on pause. It may or may not ever get done. But I've actually really enjoyed branching out and launching myself onto social media as kind of a different voice within the OBGYN community. I feel like there are a fair number of OBGYNs on social media, less high-risk OBGYNs on those apps. And I still think that my take on things or the things that I choose to post about are a little bit different than what some of my peers are doing. So I hope that that the people that are looking for that difference that we find each other, and it's been fun.
Yeah, that's awesome. And that's, I think, also like what gravitated me toward you is because I talk about risk and I don't see a lot of OBs necessarily addressing some of the things that you are. And so I feel like it's nice to see because sometimes I'm like you can't like lump OBs all into one category, which tends to happen, which I'm sure like frustrates you. And so it's like, okay, am I crazy for thinking like our cesarean rates unnecessarily high? Am I crazy for like, this? And it's like, no, there are OBs out there who are talking about the same things, who want to make a change, who want to spread this information on how to avoid an unnecessary cesarean and want to spread information on when you really need one. And so it's so great, like everything that you're sharing. And and so what I would like to talk about is like risk a little bit because I find that everyone gets thrown into these risk categories and that we're all kind of treated the same, even though like risk is like a sliding scale. So it's like, okay, I'm over 35. It's one strike against me, right? Like if this was my first kid, another strike against me. If my BMI was like slightly over what it should be, another strike against me. And it's like, do all of these things like actually make you quote unquote high risk? Or like, how can we like know when if we're just being lumped into a category, how can we know when like we are actually high risk or not?
This is a great question, and I think that you could get different answers on this,
Yeah.
depending on where you're located. So, for me, I'll answer that for me. And I think there are some general guides and different things that many high risk OBGYNs or general OBGYNs turn to understand risk categories. And most individuals are going to fall somewhere between low to mildly increased risk during their pregnancy. There's a smaller category of individuals that truly have a condition that has significantly elevated or what we call high risk. That's a very small category. And um, but there are some regions, for example, some areas of affluence where, just being IVF, you're going to be considered high risk, or just being over 35, you're going to be considered high risk. But the reality is that that is very likely just kind of a mild elevation. You're kind of in that middle group, and the middle group is large. There's a lot that can fall into the middle group. Essentially, you have no risk factors, you're low risk. You have some risk factors, that's the middle group where the majority. There's a lot there. And then high risk is a very small select number of people in that category. And so there are a lot of these different things that just mildly elevate risk. And what is risk? Risk is this, there are things that could happen or things that do happen more often for people with these characteristics than those who don't have these characteristics more often, but not necessarily the majority of the time. So most of the time when we have a risk factor, there's a mild elevation of something that could happen, but still the great majority of the time, people are not going to experience those risks.
Mhm. I love that answer because so many people do fall into the middle, but I'm finding that that middle category is all treated the same. Like as I was saying, it's like, okay, like I can't tell you, I'm that person like at a baby shower and there's a bunch of pregnant women there and they're all talking about why they have to be induced. And I'm like trying so hard to keep my mouth shut because I'm like, okay, I'm not their doula. I'm not like, like all these different things. And like I kid you not, like at a baby shower a couple years ago, there was 3 pregnant women and they were all talking about how, oh, well, the doctor told me I have a big baby, so we're scheduling my induction. And the doctor told me, like, I'm getting close to 40 weeks and like my placenta is going to start aging. So we got to schedule my induction. And everyone's just sitting there. And I'm like, like you have to, like, not presenting the information of both sides, right? It's like there is a time for induction, absolutely. But you also need to know the risks and when that's necessary. And just because you might quote unquote have a big baby, like why do you have to induce?
Right.
So and like a bunch of times that's wrong. Like it's like, so it seems like a lot of people in that middle category are treated as the high risk.
Yeah. Well, and I think to a point that I think you're you're dancing on, um, people aren't always counseled on the risks of intervention. So there are risks that we have based on our own personal characteristics. But then for everything that we attempt to do to achieve some good in medicine, there's a risk often
Hmm.
involved in that. There are risks in the choices that we make to do or not to do. There's risks involved in induction. There's risks involved in hospital birth. There's risks involved in staying pregnant and waiting for spontaneous labor. There's risk involved in all of life's decisions. Every crossroad, there is the potential that something could go wrong. Does it go wrong the majority of the time? No. In much of life, there are so many different opportunities that where something could go wrong. And the great majority of the time, the reason why life is continued is that the great majority of the time, what can go wrong does not go wrong.
Hmm.
Um, and so, but I think it is important to acknowledge that there are risks on the side of staying pregnant as well as on the side of being induced, and they're different. And who they affect is also different. So the mom has some mild risks as the pregnancy advances. Some of the things like preeclampsia or gestational hypertension are more likely to happen in the later weeks of pregnancy. So that's a potential thing that for some moms, as they stay pregnant later, could arise for them. Um, but really, the end of the pregnancy, we have concerns about the fetal risk. So in pregnancy care, that is one of the only areas of medical care that has two different entities being incorporated into consideration at any given time. And sometimes the risks to them are different. What is best for them could be opposing. And so we need to be honest and transparent about who is at risk and what are those risks. So maybe there are decreased risks to the baby with induction compared to staying pregnant past term, but there are risks to mom with induction. And I don't think that moms are always getting that full transparency. They're just being talked to, from what I hear, their takeaways, oh, this is higher risk. To whom? To
Hmm.
you or to your baby? Oh, if you do this or you don't do this, concerning things could happen. To who? To me or to my baby? Or, or to both of us. And I think it's very important for moms to have the full information and then decide, okay, now that I know the different risks to me, the different risks to my baby, the risks of these interventions that are proposed, now I'm going to decide which risks are the ones that I want to take. And I don't think a lot of times OBGYNs have the time to do that conversation justice. There's a lot of volume going through an OBGYN's office. And you asked me before we started recording, what do I think about doulas working with OBGYNs? I think moms seeing an OBGYN would get the best out of their care if they also have a doula on their support team. Because the typical OBGYN does not have time for all of these conversations. But that does not mean that they are not warranted and that the moms don't deserve these conversations. It just means the model that most OBGYNs work within does not facilitate for patient education. It does not facilitate for client education. And so then the role of the doula is even more amplified, I think, for that client that's getting their care with an OBGYN.
Hmm. Yeah. Yeah. I love that. Yeah. As I was saying beforehand, it just, I've like worked, I have only had like one birth where the provider was like not very friendly toward me years ago, but for the most part, like I've been received very well, like at births. And for a while, I actually worked at a hospital, and the providers were always happy when we were there because they were busy and they're like, oh, great, I don't have to check on you. I know that if you need something, like the doula will be like, hey guys, like we need you in here, like, so it's I have had some clients, providers be like, why do you think you need a doula? And I'm like, is your provider gonna be in your room for your entire labor? Are they gonna be helping you? Like, most likely not,
Or even the preparation. I think
Right.
um, there the childbirth experience is like the pinnacle event, but you have to in the best scenarios, I think the moms that have the best experiences, they've prepared themselves mentally. They've started to do some physical preparation. They've learned, they've asked questions of themselves. They've thought through some different scenarios. That starts all well before you get into labor. And so it's not just, is the OBGYN going to be there during the majority of the labor, which they won't. But it's also, what about all of those months and weeks ahead of time that we were trying to decide, you know, for ourselves and make decisions about the experiences we want to have to get prepared for childbirth and postpartum. What about all that time that needed to be invested to answer common questions, to talk through concepts? Like they don't have time in that part of the pregnancy either. Um, and I really think that doulas are doing a great job at broadcasting their role. Um, I think that as more and more people become aware of what the concept of a doula encompasses and what they offer, what they bring to that pregnant person and their family, and I think as that exposure increases, more and more people in the workspace, like the OBGYNs and the nurses, I think that they understand a little bit better and are less when there's unfamiliarity, the Western medical community can be very skeptical and standoffish. They're not inviting of new things into the space or the unknown. They're not as inviting. And so I think exposure really helps them stop the othering and say, okay, now I kind of understand what this person does and what the purpose they serve. And I think as people then work with a doula and see behind the curtain of how they serve the client, that shared client, then they realize, oh, okay, this is actually a good thing. Like I don't need to be afraid. And honestly, I've even posted on this that most OBGYNs should welcome a doula involvement, because when that mom then looks back on her experience and has better satisfaction, better breastfeeding rates, lower C-section rates, overall has major areas that we are trying to improve maternal and child health outcomes that they are doing better at. That looks well on the OBGYN.
Mm-hmm.
But right, so the involvement, we know it's the involvement of the doula that is helping achieve those better outcomes, but that then makes the OBGYN look like they did a good job. So
Mm-hmm.
honestly, I think this is a win-win. I think that OBGYNs need to embrace doulas to say, okay, I know that my model has limitations, but when I partner with this support person, then overall, my client is going to be at a higher likelihood of better outcomes for multiple different things and be more satisfied with their experience that I am a part of. I think this is a win, but I don't know that the general OBGYN community has yet embraced it as a win, but I see it as a win.
Yeah. Well, the way you describe it makes perfect sense. Um, I do have one question before like moving on to some more like high risk stuff, since we're talking about doulas and providers. Because the way that I was trained was I was taught very clearly that as a doula, you are not an advocate. But I have since changed my thinking. They were saying you cannot advocate. We're not supposed to be called advocates. Like you can't speak on your client's behalf, which is like true to an extent for sure. But what would be the best way as a doula if you are witnessing maybe like some fear mongering or not like consent, and you're just like at a birth where things are really not great? Usually like if something comes up, like if a provider comes in and is like, okay, like I really want to start you on Pitocin now, blah, 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 blah. We're usually like, okay, can we have some time to think about it? We discuss things, and talk over what our options are. And we might just be like, hey, can we get the breast pump for a while? We're going to try that and see, like if it gets things moving. And so we usually talk through things. But if you're like truly witnessing like something, because I've heard stories. I haven't been at a birth. I've been at one birth with, it was actually a midwife who was the water had been broken for about like 24 hours, but she had zero signs of infection. Everything's going fine. The midwife comes in and says, if we don't have a C-section, your baby's going to die. and there was like no sign of anything. So like what do you do in these situations maybe where you are like witnessing that like extreme like fear mongering or they're like, oh no, like just like not being listened to, their autonomy is like not respected. Um, like as a doula or a support person, like what would be the best way to like address that situation?
That's a challenging question. I think it's challenging for me because I don't know any legal limitations for your role.
Yeah.
Um, um, I think that it's appropriate for anyone that a birth person brings into their labor room to be an advocate.
Mm-hmm.
If that mom brings that person intentionally with them to be there in that very vulnerable, intimate experience, I think it's appropriate for them to be an advocate. And I would say that in my experience as an OBGYN, I have often had people in the room speak up on behalf of that pregnant person. And some of what have had to do is also just try to make sure that I heard from that birth person. I heard from that pregnant individual. I hear your family advocating for you. A lot of times there's family in the room that are asking questions and trying to speak up on behalf. And I just also want to make sure that I'm not um, taking their word for what that person wants, because sometimes some people are really vocal and it's not necessarily what that pregnant person wants, but that person with them is the loudest person in the room. But either way, it's still our role to give space and respect to those companions that person brought with them, and to address all of it, um, not to let that other person be a proxy for the voice of that pregnant individual, but still to respect what they are contributing to the conversation. So I don't have a problem with the doula seeing themselves as an advocate. And I question that the pregnant mom may see the doula as an advocate and may
Yeah.
want the doula to be in that space to help advocate for them because of the experience that you have at being involved in birth, seeing things frequently. For the mom, depending on how many children she's had, or what her experience has been, that she may look to the doula for the doula's experience. It's saying, oh no, this is weird, or let's talk, or I don't like how you're being treated. Or to affirm if she feels weird about something and is questioning, is it just me? Or do you agree with this? So I don't have a problem with the doula being an advocate. And I don't know if that's just because I'm biased. I'm very supportive of the concept of a doula, and I'm very supportive of maternal autonomy, and I'm anti mistreatment. So I don't have a problem with that. Um, so I think it's still appropriate for you to say, can we have some time to talk about this?
Mm-hmm.
And and try to clear the room if it's not an emergency. And the example you gave didn't sound like an emergency. Clear the room if it's not an emergency. Get that negative energy out the room, and like do a debrief and talk, and um and fill out what that pregnant mom is thinking, where she is in her mindset and her energy and in her heart and her in her vision of what she thinks could still happen, or whether or not she's pivoted. I think that's still appropriate to say, if it's not an emergency, can you give us some time to think about this? And then, to make some decisions. Okay, do we need to change providers in
Yeah.
labor?
Mm-hmm.
You know, are you being mistreated? You know, are you being mistreated? Or is your autonomy being supported? Is this provider creating a situation that is more more harmful is counterproductive? Do we have questions? Do we want to ask for a second opinion? Do we have questions about this provider? If it's not an emergency, you can get a second opinion. There are other providers usually on a labor floor. There's usually a chief of obstetrics. There's often, different people that you could say, you know what? If it's not an emergency, I want a second opinion. I want somebody else to come and review this situation. Give me some time.
Mm-hmm.
So I don't have a problem with that. But I do want to acknowledge that there are a lot of providers that don't like being challenged in their authority. That's not right either. But there is often a confrontation that comes up when people are challenged. And that's not supposed to be what pregnant women experience, but that is the reality that I think a lot of women are experiencing.
Mm-hmm. Well, you said a few times, like, if it's not a true emergency, like, how do you know, like, if
Yeah.
it is a true emergency or not? Like, if they come in and they're like, okay, like, the baby's having some unreassuring heart tones, like, we want to prep you. And you're like, okay, can I just like have a minute,
Yeah.
or like the example that I gave, she came in and she's like, your baby's going to die. Like, if we don't have a C-section, even though there was zero signs of anything. So how do you know? Like, because we're not doctors,
Yeah.
like the client's
Yeah.
not doctors. So it's like, how do you know? But I think asking for time, like if they give you time, then it's not a true emergency. Like if you're like, you know what,
Absolutely.
let me just have a minute to think about this, to like whatever, maybe you will get a little pushback of like, you know what, I really think whatever. And if you're like, just give me a couple minutes, usually that puts off whatever like interventions being brought up. Like I've been at a lot of births where they're like, okay, we want to start you on Pitocin. And it's like, you know what? Like, we're not ready for that. Like, let's try a few things. And they're like, all right, like, we'll check back in 6 hours. And it's like, okay, so this isn't a necessity, And then they check back in 6 hours and we're like, we're moving things along. We're fine. And they're like, all right, we'll check back later. It's not a necessity, So sometimes information is given as in, okay, we need to do this thing now. But when you ask for that space, it's like, okay, like, I guess we didn't need to do that thing right now, but we do need to have a plan of like, how are we going to do this? Like, are we having movement in labor? Are we, like if you don't want like an IV to stay hydrated, you have to make sure that you're drinking a lot of water. Like or not even just water, like coconut water, like some sort of electrolyte drink, like something to keep you hydrated, because dehydration in labor can stall your labor. So like being fully hydrated has shown to speed your labor up. So it's like, okay, if you don't want to have the fluids, how are we going to manage this? If you don't want to have the Pitocin, um, and let's say you are starting to show signs of fever or whatever, like how are we going to get your body moving? Like, so I think there's like such a balance there, which I do love the whole, like, as you're saying, like doulas working like with OBs, because I feel like having a full supportive team, because we all want the same thing. We want you to be okay. And we want you to have a good experience and to be healthy. I don't like the saying healthy baby, healthy mom, because I think it's so much more than that. Because that doesn't take into consideration like the mental health aspect. They're like, oh, well,
Yeah.
you lived, your baby lived, you guys are both healthy. And it's like, okay, but these traumatizing things happen to me.
Yeah.
Like it doesn't validate really the experience of how you got a healthy baby.
Yeah.
So it can be tough, but yeah, I know I just kind of answered my own question. I like asked it and then like answered it in a big sarcasm.
No, but that's great. You did answer the question. And so I think just to affirm that, um, if it's an emergency with the baby's heart rate, usually the behavior is different. Usually people come in rushed.
Mm-hmm.
And you've probably seen this. Multiple people come into the room, the intensity is heightened. People are talking fast and they're like, we are very concerned about what is going on right now with your baby. And usually the fetal heart rate tracing looks like this. And the heart rate is just going down. The ski slope is just jumped off. The ski slope is just traveling down and doesn't look like it's coming up at all. So And I think it's totally appropriate to ask, is this an emergency? And they should be honest with you. If it is, yes, we're very concerned about the fetal heart rate tracing. It's not coming up, it's just plummeting down. We don't know if we have time to do a lot of different things. We need to prepare. Like, you'll feel that energy if it's a real emergency. Most of the other times it's not. Most of the other times there could be a pattern that's becoming more common with the fetal heart rate that's concerning, but it's not an emergency. It's just becoming more frequent. And maybe one person will come in very calmly and start to talk. And then you could say, is this an emergency? Do we have time to think about it? And I think, if one person comes in, they don't seem like they're in pressured speech. They're not like seemingly trying to keep their composure from freaking out. It's not an emergency. This is an opportunity to think about some things and make some decisions. So I think asking that question, feeling the room, will help you gauge, okay, I have time to get an opinion on this, to think it out, to maybe stop and reflect. Or if it's an emergency, multiple people are coming in, and then you feel it and you're like, okay, wait, no, I need to make a decision now about what's going on.
Yeah. To kind of go back to high risk, like let's say, I think it's important to kind of be educated on like what could potentially make you high risk, because we all have different individualized risk factors. And instead of like just being, as you said at the beginning, like thrown into this category, because I already know that, I had my last baby at 37 years old. So like, I already know I have one elevated risk factor, right? Doesn't mean I'm high risk, but there's an elevated risk because I fall into that over 35 category. And so, and at my last birth, I had a significant hemorrhage. So I have an elevated risk my last baby, because my second kid, I had a significant hemorrhage. So with my third baby, I had an elevated risk of potential for a hemorrhage. So like knowing these things going into it, I was able to just kind of be more aware and plan and prepare a little bit differently. And also know like what my options were for managing postpartum hemorrhage. And so if you know that have potential risk factors, are there ways that you can lower that risk? I know I can't change my age, right? So, but certain people fall into different categories. And if you know what that is there potential to like maybe lower that so you're not just like lumped into this high risk group?
Yeah. Yeah. So I think being informed and taking the opportunity during pregnancy to listen to podcasts, to read different pregnancy information resources, to watch videos put out by people that are reliable, to consume information about pregnancy, I think is going to help so many moms. I think there are a lot of moms that they don't either have the time or don't think about trying to inform themselves, and the provider hasn't talked about it, and so they just go with the flow and they don't know what they don't know, and sometimes if things occur, they're like, man, I wish I had known that. So I think pregnancy education is really helpful. I think it empowers people. One of the most common risk factors for pregnant moms in the United States is being overweight or having an obese range BMI. There are a lot of things that we are exposed to during pregnancy that are stressors, whether it's things in our food, in the air quality, in the water, relationships, the demands on a pregnant mother, work. There are a lot of different things that are stressors. And those stressors can actually lead to true problems in pregnancy. They can kind of add together negatively and impact a mom. So I think one, for moms, talking and finding out some of their different factors that are risks that they might have to either. There are a lot of people that they come for a consult with a maternal fetal medicine physician, and they don't know why they're there. And the reason they're there is because their general provider has identified that they have multiple risk factors, and then they want us to talk about about those things and to create some recommendations for that pregnant mom that the general OBGYN or the nurse practitioner or nurse midwife can then follow those recommendations. So if you go for a consult with a maternal fetal medicine provider, read the note, pay attention to the things that they are outlining as like these risk factors that you have. And then you can do some more investigation of those particular things or read your own medical chart. Doctors, most medical providers at this point are keen on, it's important to identify different risk factors that pregnant moms have. And so they will itemize those things in the medical chart, especially in an electronic medical record. Look at your medical record. What things are outlined there? Okay, if there are different problems in your problem list, those are potential things that your provider has determined from talking with you and looking back at maybe your past history, these things could become more complicated during your pregnancy. If they've outlined these different problems that you have, treat those as some of your risk factors for things and then learn a little bit more about that. I would say that many pregnant moms could decrease their overall risk by information, by having a healthy diet that's rich in antioxidants, in natural, in real foods that's less processed, moving their body regularly, even low impact movement like walking or doing things that decrease their stress, like yoga and stretching. Being in relationships that give them joy, whether they're friendships or their relationship with their partner, or doing things to allow them to experience joy and community. All of that supports healthy hormone development, decreases stress levels, and I think in general undermines some of the things that can kind of erupt in pregnancy. There are different moms that have risk factors for things like preeclampsia or hypertension or gestational diabetes, depending on their previous pregnancy experience or their own personal characteristics or their family. Learning about some of that. Aspirin helps with some of those moms that are at risk, elevated risk of preeclampsia, but also those same things of limited weight gain, good nutrition, moving your body, keeping your stress levels low. All of that helps to try and decrease some of those outcomes as well. It helps to potentially decrease the preterm birth outcomes as well. So those are some of the things that I would encourage. But there are going to be high risk moms that don't know they're high risk.
Mhm.
So let me talk through briefly just a few scenarios that are truly significantly elevated risk, what we call high risk. A mom that has lupus with hypertension or heart disease, a mom that was born with heart disease, who had surgery on her heart and then gets pregnant, has replaced heart valves, a mom that has cystic fibrosis and has multiple infections, is on medication for recurring pulmonary infections, moms with type 1 or type 2 diabetes, especially the type 1 diabetes or advanced diabetes that already has involvement in the diabetes in other areas of their body. They might have some blindness or some heart condition, or they might have hypertension. Moms that have previously had blood clots in the lungs or the legs related to pregnancy or when they were on, birth control. Moms that have cancer during pregnancy, right? So moms that have had a heart attack or that have a heart attack during their pregnancy, right? These are very uncommon, right? So as I'm talking through this, you realize I'm not saying 35 or older. I'm not saying I'm talking about significant pre-existing conditions. Those are the moms who have high risk, right? Some of those moms with pulmonary hypertension, those are the moms that are pregnancy can be extremely dangerous for them. Those are the high risk moms. And then there's a lot of other moms that have some moderate risk factors for complications, but they're still overall very likely to have a normal, healthy, safe pregnancy. But all of those moms would benefit from learning about pregnancy, some of the potential complications that they may be at risk for, and ways to try to just thrive in their pregnancy, to manage their diet, manage their weight gain, make sure they move, keep their stress levels low. all those things I think would help many moms.
Yeah. Yeah, I know. When you were listing that, I'm like, yeah, all these situations sound high risk. Like, you know, it's not like, oh, somebody, yeah. I guess like how we kind of get lumped, it wasn't like those. So as you were saying, like a lot of people, even if they fall in that middle group, are most likely to have healthy pregnancies and healthy outcomes. So what do you think is contributing to our high C-section rate in our country? Because we know that it's significantly higher than it should be. And then having C-sections puts you at risk for different things, different outcomes that could potentially happen. And I realize that that's not talked about a lot. I've had clients or friends, mostly friends, family, be told that we're just going to have a C-section because of X, Y, and Z, but not given the risks of that versus like, VBAC, like not giving the risks of repeat cesarean versus having a trial, a TOLAC. So, so first of all, why do you think our C-section rate is so high? And then I'd love to maybe then go into VBAC a little bit.
There are multiple reasons that all work against the C-section rate being better. One, OBGYNs are not midwives.
Yeah.
So, the training is different. OBGYNs consistently around the world have lower C-section rates than OBGYNs. So there's definitely something in the midwifery model that is significantly different than the OBGYN model that contributes to the C-section rate. Then you have a lot of variation in how people respond to fetal heart rate changes. There's a lot of interpretation that varies when it comes to fetal heart rate changes that are of concern. So that is driving it. And that's another thing that OBGYNs might do differently than midwives. A lot of midwives might do intermittent auscultation and labor versus a lot of OBGYNs, their clients have continuous monitoring even when they don't need it. Even the low risk mom who doesn't necessarily, who may go in before she has an epidural is still getting continuous monitoring, but she doesn't actually need it at that point in time. Or it's not, it doesn't have to be an automatic, but it's almost always automatic because it's just the routine. Now, when we do different interventions like Pitocin or epidural, or different medications, we change the risk factor during labor because of those interventions. And then continuous monitoring is now then warranted because we've changed the risk by introducing these medications that may not be well tolerated by the fetus. So fetal heart rate concerns and like a variation in how people respond to them is part of the issue. Then you have labor management and variations in people's patience or understanding of I would just boil it down to patience. Variations in patience and what people's expectations are for a pregnant person and while they're in childbirth, like when they think they should move through different stages. And there are a lot of providers that are inappropriately recommending C-section too early. They are they are at the phase of labor where there should be no expectations on that pregnant individual, and they're already putting them on a time clock and saying, oh, well, clearly your body is not going to do this, so let's move forward with C-section. When we ask providers and we hold them to follow the American College of Obstetrician and Gynecology's recommendations on labor terms and when to not call a C-section, the C-section rate goes down. So that means that people are jumping the gun. There are too many C-sections being offered for a mom that's not even dilated. 1 centimeter dilated, 2 centimeters dilated. Oh, you failed to progress. There is no progression expectation at that stage. We don't have any expectations of a labor curve, of any significant pacing to labor changes until somebody gets to 6 centimeters dilated. And that's naturally dilated, not I dilated you with a balloon and it came out at 6 centimeters. You are still very likely in the early phase of labor that has no timeline on it. And if those moms were laboring at home, they might labor for days at that stage before they progressed into the active part of labor that has a certain momentum to it that picks up in intensity. So there's that. There's a lot of lack of patience. Um, and then, still on this patience topic, our moms are heavier than they were before. And one of the things that I don't think a lot of providers know or acknowledge in practicality is that plus size moms may labor longer. Their labor curve may be different than a mom who does not have an elevated BMI. And we see that plus size moms have even higher rates of C-sections than moms that have a BMI less than 30. The evidence is starting to show us that more of them labor longer. Their labor curve is shifted over by a few hours. And so if we don't acknowledge that and allow for more patience, if everything's fine, then we have these high C-section rates. There was a beautiful study that I was just marveling at. It was done, I think it was in the United States. I don't think, yeah, it was in a smaller community in the United States. They put 4 things into practice, and in 1 year, dropped their C-section rate in half. And I was like, 1 year, you saw that dramatic improvement in 1 year. They went from a C-section rate that was very typical, nearly 30%, I think it was like 28%, down to, I think, 12% or something like that in 1 year. And this is what they did. They provided training to their staff on intermittent monitoring, intermittent auscultation, and started using it more for those pregnant individuals, those birthing moms that qualified for it. They started using intermittent auscultation more. And sometimes when you are not looking at that fetal tracing as much, sometimes that's okay. Sometimes that's better to not just be looking at it all the time. And then they stopped inducing moms early. They had a general policy that if you didn't have a reason to be induced, they didn't induce anybody before 41 weeks. Then their triage providers, they didn't admit people for labor unless you were 4 centimeters or more. And then they started providing the C-section rates to each provider monthly. And now you're going to introduce competition, because
Yeah.
I don't think the community realizes that many OBGYNs don't know their C-section rate. They don't know the rate at which that low risk mom with a singleton baby who's head down has a C-section. They just may know maybe their hospital's C-section rate, but they don't know how they contribute to it, because that putting that together takes some different codes, and it's more documentation and logistics than they would be probably keeping for themselves. They're probably not keeping that information for themselves, but the hospital knows. The hospital knows that data, and they have people that are doing analysis of big data, and they can tease out the individual factors. And I remember when I was a resident, I was like, why don't we tell these groups, as residents, we knew who the offenders were. We
Yeah.
we knew the groups that had high C-section rates. We knew who was contributing to the problem. We knew that at 7 a.m., if you were on call overnight, we knew that provider was going to come in. And if that mom wasn't already pushing, she was getting a C-section, because that was the habit. We knew who these people were. And I used to think, why don't you just tell them? Why don't you call them out? Like, why don't we make it public, even in amongst our community, when we have these community meetings for the providers that deliver at the hospital, the groups. I mean, this is not necessarily open to the public, but why don't we in community call each other out and say, okay, group, you have a 50% C-section rate. You're contributing to the problem. But that transparency just wasn't there. And so this study, they told the providers, and I don't know if providers knew each other's score, but even still, once you know that you're above goal, that you are not meeting a high performance benchmark, a lot of physicians are competitive. So now you introduce a competitive factor. Well, okay, I'm not at goal. I'm going to try to get in the target range. And I'm very confident that that factor made a dramatic difference in the individual performances of physicians by being able to give them that feedback of where you stand in respect to the goal that we are trying to get to. So in a year, they went from being typical and excessive, which is most hospitals are in the typical and excessive range, to now being in a category for a hospital of having one of the lower C-section rates. 12% is remarkable for a hospital. It's
That's
remarkable.
unheard of.
I remember I worked at a hospital. We had a 12% C-section rate that I walked into. I didn't contribute to it. I walked into it, and when I heard it, I was like, "Wow!" And when I told people, their eyes were like, "That's unheard of." I was like, "Yeah, like man, I'm so impressed with this place that I'm working at. Like, I don't know how they did that, but they had a lot of different things they were doing. They were following the recommendations. They gave people time. They had a lot of midwives involved. And they had a lot of providers that had skills at delivering maybe a twin breech or doing forceps. And so a lot of things just really help for vaginal delivery. Um, but those four changes, a hospital saw dramatic turnaround, and they're not hard changes to implement. They're not. And
Mhm.
many, the knowledge is there to do that. These are not novel, groundbreaking changes. These are adopting some things from the midwifery practice, de-implementing some things that people do too often, setting some consistency of when to do elective inductions or when to admit someone for labor, when somebody might actually be in labor. So, um, and then transparency to the clinician about where they stand in the C-section rate issue.
Yeah, that's awesome. I wish more hospitals would do that because that drop rate is insane. Um, and I love that you talked about like just like all the different things that are contributing to this C-section rate, because I was reading the other day that failure to progress is like the number one thing, and then the fetal heart tones is the second thing. And it's like such a gray area. There isn't like this is when you intervene with fetal heart tones, and this is, it's like so obscure. And so you just see it treated so differently. And um, yeah, it's hard. I think it'd be really cool to show providers like their personal rates and see if like that
Yeah,
improves things.
and we didn't even talk about after a previous C-section. So that's another area that contributes to the high C-section rate is the overall fear um, of someone laboring if they've had a previous C-section. And so once you've had one, then 90% of moms who've had one C-section get a second. So so once that door has been opened, and many of those moms they've been taken advantage of because
Mhm.
we know the data's out there that the majority of C-sections are unnecessary. So the first one gets thrown in, and that mom is being taken advantage of. She doesn't know the system. She's not an OBGYN. She maybe doesn't have a doula. Nobody's advocating for her. She's completely vulnerable to the medical hierarchy and the authority of this provider that comes in and says, this is what you should do, right? If you don't do it, there are going to be risks. Without talking about the risks of future C-sections, the risk of complications after C-section, even the risk of your baby being injured during that C-section, they're like that C-section delivery is not risk-free. And we don't talk about placenta accreta, which is almost 100% driven by the C-section crisis. What we don't talk about how moms can go from one unnecessary C-section to hysterectomy in their subsequent pregnancy from placenta accreta. I one of the hardest clinical scenarios, emotionally hard, that I've had in the recent past was a mom who was had a C-section because of a very traumatic event that happened in a first pregnancy, very traumatic labor event, uh, lost, had an intrapartum loss, and very likely was traumatized by that and elected for a C-section in their second pregnancy. And in their third had a placenta accreta. And it was the largest emotional curveball that we threw at her. For her to say, this is going to be the last child that you carry in your body, that we're going to recommend taking your uterus out because of how dangerous this is. And that is an artificial problem, almost always tied to C-sections.
Mm-hmm.
Almost 100% tied to the C-section epidemic. So we don't talk about that. We don't talk about okay, if I do the C-section now, would I support you to labor in the future? The answer, great majority of the time, is no. I'm not going to support you in the future.
Mm-hmm.
Right? And so that it's I think the more a mom can inform themselves of different things, I think that they'll have more power to evaluate the situation and decide whether or not, you know what, I'm not going with that recommendation, or I want some more time. I'm not ready to do that. I don't think it's time to do that. I'd like more time in this situation. And a lot of times more time is more than appropriate and will allow for vaginal delivery.
Mm-hmm. Yeah. I've talked about, I had a VBAC episode. I've done a couple about placenta accreta because it's like, yes, the reason providers are like scared of repeat or of like a VBAC is the chance of a placental abruption, correct? Is that usually,
No, they're
or
mostly
uterine rupture?
yeah, uterine rupture. Yeah.
Yeah, that's what I meant. So a uterine rupture. So it does increase, but they're not talking about the increase in the placenta accreta, which can be fatal. So it's like it's like such a higher risk. And people aren't counseled on how big of a family do you want? Oh, you want to have 4 kids and you're starting out with a C-section? Like that might change your plan of action, you
Yeah.
know?
You used a very powerful word, fatal. Um, when we look at the concerning statistics for Black moms in the United States surrounding childbirth loss, childbirth death, C-section is very much involved in that issue. C-section is the hidden elephant in many of those rooms. We look at these moms that the hospitals fail to respond to postpartum bleeding, or they had these complications, and a lot of times there's a hemorrhage component. When you look through the details, there's a C-section involved in many of those scenarios. We don't talk about how C-section increases the maternal risk of not surviving the first year of
Mm-hmm.
pregnancy. We don't talk about how it has a almost 5 times higher risk of mom not surviving the first year postpartum. Right? So and that each C-section continues to elevate the risk to mom.
Mm-hmm.
And so it's not even just if an accreta happens, even after a C-section, a mom could have a devastating complication. And yes, the overall number of moms that have C-sections are going to survive them. But there's a higher risk, where we talk about risk all the time. There's a higher risk of maternal mortality. There's a higher risk of injury. We're learning things about kind of the long term, a year, within the first year, not just within the first 6 weeks. There are greater risks to mom sometimes with C-section. And then also we're learning that C-section has risks for the baby, that individual child could have an unintended injury during the C-section. Their microbiome is different from their peers that came out of the vagina. Their health may be different because their microbiome is different. There's some concerns about increased risk of ADHD in babies born by C-section compared to vaginal birth. There's a host of, the moms are often less likely to have long-term breastfeeding success compared to the moms that deliver vaginally, which also then is implicated in mom's health risk of different factors that are affected by breastfeeding, and then baby's health related to risk factors that are affected by breastfeeding. There's a host of things that we don't that the moms don't know the domino effect.
Mm-hmm.
They get one morsel of information from their provider, and then there's this whole screen projector of things that are not being discussed, that they just don't know.
Mm-hmm. And I guess like the frustrating part, because like you said, it's this huge like trickle down effect, like even to like your future risk of cervical cancer, right? Like it's like how, but I mean, is this like common knowledge for most OBs? Like, why is there not like on the OB side, them knowing, hey, we know that there's increased risk with placental accreta, like with a lot of C-sections. So why are we doing them? Like, how come? That's like, I guess, like where I struggle with it. Cause I'm like, obviously, like we acknowledge that cesareans are there for a reason. There's a time and a place. And there's a huge time and a place for VBACs. How you said like 90% of women are just having repeat cesarean, but like 70 to 80% qualify for a VBAC. And only like 10% or something are doing them. So maybe 12, I don't remember. So it's like, why, if OBs know the risks of these repeat cesareans, why are they doing them instead of counseling you on whether you're a good candidate to VBAC?
Several things are involved in this answer. One, OBGYNs don't always know when they are contributing to the problem. They don't have that transparency always to know that they have an excessive VBAC rate, or a excessive C-section rate. And many providers, I do believe, they think a C-section is warranted when they offer it. I think they are convinced that
Mhm.
is the right thing to do. And a lot of the time, their conviction is wrong, right? So there's a disconnect. A lot of them do think, oh, this is failure to progress, a failure to dilate, and it's the wrong definition. It's not, we're not at that phase. So there has to be a kind of a policy change of, these are the standard terms that we are going to hold you to. C-section should not even be discussed unless these thresholds have been crossed. I think we can't, I think there has to be some structure that calls on the accountability of the provider. If we just leave it up to their discretion, then there's too much discretion going on, and the subjective, the threshold to offer the C-section is too low. Then the other factor is fear of litigation. And litigation is a very real factor. It is a entity in obstetrics. Many OBGYNs have been sued, whether or not they were doing their due diligence or not. It doesn't matter. You can be sued even if you crossed all your T's and dotted all your I's. But if an outcome happens despite that, and especially if that mom is dissatisfied with the experience that she had, she can absolutely find somebody to sue you. And the process of being sued is emotionally challenging. It is potentially trauma inducing. It undermines many physicians, and what they do after being sued may be different than how they practiced before they were sued. And then the desire to avoid being sued again or to ever be sued in the first place, people do things to avoid being sued. So labor is riskier sometimes, is more unpredictable sometimes than C-section. And the lawsuits, the most of the lawsuits are going to be for the child. When families sue their obstetrician, the great majority of the time, it is going to be for, well, I don't know if I know the statistics, so let me let me, but I suspect, and of all the lawsuits that I am aware of, they've all been for childhood outcomes. So almost all of them for the OBGYN. GYNs get sued for different things, but most OBGYNs, when they are getting sued for outcomes that happen to their child. And so C-section is thought to be protective for the child and to decrease the chance they could get sued for an unpredictable labor outcome in vaginal delivery for this child. So there is a litigation aspect to why the C-section rate is so high. That's also why the labor after C-section rates are so low. If you have the very rare occurrence of uterine rupture and then severely have injury to your baby, or your baby either is lost or has permanent disability from decreased oxygen, which happens a fraction of a percentage of a time, right? So there are uterine ruptures that go without any warning signs. There's no perceived injury, and then it's found incidentally after delivery. And then there are the smaller fraction of cases where it's catastrophic, okay? But the catastrophic ones are on people's minds. And so they say, well, I don't want to take that chance. I don't want to take that chance that that rare thing could happen to the client that I'm working with, and they would have sued me for supporting them to labor. Labor was the factor that elevated this risk. If they just had a repeat C-section, they wouldn't have the opportunity to have a child that was permanently disabled by an extreme case of uterine rupture. And so that goes into these VBAC bans. And these, no, I'm not going to support labor. Once you have a C-section, we're always going to do a C-section, right? That goes into that. And so I don't know how many people are aware of how much fear of litigation or previous experience with litigation influences obstetrics. But it is a very real and present entity in obstetric care.
That makes sense, especially since you said like people are more likely to sue over a baby. Whereas like you see more moms harmed through cesarean versus babies. So that does make sense. It makes sense. But it also like sucks. That's why like the whole system just like isn't set up great. I remember I interviewed an OB like several years ago, and she was just talking about how just even like with insurance, she's like, I would love to spend 30 minutes with 10 patients a day, but instead I get 10 minutes with 30 patients a day. Like, like just the way that it's set up, it's not set up to really support everybody, which just stinks. So one more thing before we wrap up, I wanted to talk about informed consent, because this is something that we don't see a ton of. It's more just like, okay, lay back, I'm going to check your cervix. There's not, and most people be like, wait, is there something wrong with that? It's like, like asking, not just like telling all the time, but just like providing autonomy and informed consent. What does that look like to you as a provider?
Great question. And I think there's a lot of room to inform providers in this topic. And I think that the moms voices need to be heard so that we understand even where it needs to go. Because, what I might assume is something that involves consent. Maybe the mom thinks, oh no, these additional things, I also want to give consent. So I really think we need to hear the voices of the moms on this topic to really make sure that the full scope of autonomy is being supported, and that we introduce a normality about pausing and asking more often than not, rather than just doing. Um, but I think that um, when it comes to anytime we're trying to do something, anytime we recommend something, or if there, especially I think procedures is where we think about them the most. For procedures, it's kind of, we have a pause and a check where we understand that a procedure has a risk. And so then we think, oh, I need to talk to this person about why I want to recommend this procedure, you talk to them about the risks of it and get their permission. I think that's where many clinicians and people that do an intervention perceive a need for conversation about autonomy and to inform and get consent. Where we really need education and kind of to learn new things is, even when you're wanting to do an exam, you need permission. And to kind of remove ourselves from this mindset of, well, I'm allowed to just do these things and tell this person that this is supposed to be the next step. There's an expectation, or there's a culture on the labor training and in the labor unit of, I manage labor. And so when somebody comes in labor, then I'm going to start doing an exam every 2 hours. If they don't make change by this amount of time, then I'm going to go in and break their water, and then I'm going to do Pitocin. And even for young trainees, they feel this pressure to do these performative things because they are trying to show people that are supervising them that they know how to manage labor. But we don't always stop and ask, Mom, are you okay with us managing this labor? Do you want your labor managed? And then we don't always counsel on, let me talk through the risks of those steps. Let me still get your permission at each of these steps. Are there risks to the things that I'm trying to introduce? And what are the pros and cons of that? I don't think that mindfulness is going into kind of the day-to-day experiences and the habits that providers are engaged in it. But I do think that that's where it needs to go. I think it needs to be a mindfulness of, I need to ask permission. I'd like to examine you. Would you be okay with that? I've been evaluating your labor, and I think that if I do this, that it could help your labor continue to progress. I get the impression that your labor is stalling here. You know, I think there's a role for ongoing information and ongoing permission. And it's not just, oh, I document this on a piece of paper. I think that's when most clinicians think about getting consent, is when they have to put a piece of paper in a medical chart and say that they inform somebody on some procedure. We don't think about all the different periods of time where we're in somebody's intimate space and touching and manipulating their body. That, did we ask permission for that? Did we ask if they were okay with these things that we wanted to introduce and intervene in their labor that have risks with them?
Mm-hmm. Yeah. Yeah. I love that you talk about that, because I do think that there needs to be a lot of education around that, because more births that I've been to than not, they just like come in and say, okay, we're going to do this now. Not like, not like, hey, I'd like to talk to you about this. Or even like I said, with cervical exams, it's like, all right, we're going to check you. Not, is it okay if we check you? Okay. You're going to feel my
Yeah.
hand. Like, there's no like conversation around it. It's just like, all right, it's time to check you type thing. And, instead of getting that permission, because yeah, when you think about it, I have issues with like cervical exams in general, like just in pregnancy, but like I, it's like you're just, to me, they seem so invasive, and there's not a lot of trauma-informed care either. Especially like when we live in a country where like 1 in 4 women has experienced some sort of sexual assault, and then, then their provider is just like, all right, like take your pants off, change, and I'm gonna check you.
Yeah.
Um, it's like, is that even really necessary? Like in these prenatal appointments? Like, what are you looking for? Like, if you're going to be scheduling an induction, sure, but like, what's like just for funzy? Like, what are we doing here? Like, I don't know.
It should
So,
never be just for funsies, but sometimes it's not going to significantly change anything. And so
right.
then the question is, do we need this mindfulness of why am I doing this? What am I going to use this information for? We need to be more mindful of the potential that person has been a victim of sexual violence. And we should be asking questions about that when we talk to moms. I know that I even feel uncomfortable asking that question, even though maybe I shouldn't, but it just seems so personal.
Yeah.
It just seems like I need to build a certain rapport with you before I can really ask you that. And maybe that's not the case, but I as a female provider hesitate to ask somebody something so personal and probably triggering. And but the reality is, just like you said, a lot of people have. And then we can get very casual with how intimate cervical exams are. Um, because we are taught that information is important for labor management. And so we want the information, and in many regards have dehumanized how we are getting that information, that it comes with a very intimate exam of someone else's private parts. And so I think maybe doulas have a a a role they can play in championing the voices of these moms, and kind of raising awareness of what are you guys doing?
Yeah.
Like being mindful, having that on your mind. This is someone's privacy, that it's not just a baby factory. This is someone's area of privacy. It has to come with a level of respect and privilege to be allowed to do some of these things, and to be very mindful of being gentle, not rushing the situation, not being an abuser in that situation. Um, and that's not always being taught.
hmm
Um, I've definitely tried to teach juniors the art of respectful examination, and being gentle in your examination, and going slowly, and getting permission beforehand, starting, not going straight for the for the genitals, when as you start to introduce the concept of the exam, watching that person as they do it. How are they tolerating your exam? Looking at them. um and it's I don't always see the trainees invested in learning that. I see this rushed disregard for what they just did, and I'm like, oh, pull them aside. No, you cannot do that. you
Yeah.
you need you gotta work on that. You need to look at her when you do that. Look for the wincing, look for the discomfort. Is her body clenching? Stop. If she tells you to stop, stop. It doesn't matter if you didn't get the information, if you couldn't finish the exam. You stop. You respect
Yeah.
her. You don't go
hmm
straight in, no intro, hand straight, like fist somebody. You don't fist anybody.
Yeah.
You go slowly, and you figure out what your fingers are doing. You try not to get carried away in there. And so, but that's it's an art. Um, it takes a lot of self-awareness and mindfulness, and not everybody's learning that, not everybody's practicing it, and we have a lot of room for improvement, and we really need to improve on that. We really
Mhm.
do. We're overdue to
Right.
improve on
Well, I mean, it's a sacred space, and I
it.
mean, it also just like goes to show just how women's bodies are treated in our culture and country in general. Like there's a lot of room for improvement on that. So it is very easy to just feel like you're in a baby factory here when it's just like an assembly line. Like you just feel like if you're at like a prenatal exam and you're 38 weeks, and your doctor's just like, all right, cervical exam, next person, cervical exam, next person, like, and that's just not, you don't want to feel that way about your body. And like, also when you're not getting that permission, like, what are you telling us about our bodies? Like, we don't deserve to like consent to who's entering our sacred space to
Yeah,
I mean, we've been given this rhetoric. Yeah, I mean, there's so much we've been giving this rhetoric ever since we were little girls, that our bodies just aren't worthy, and you just like see that play out in so many different situations. And so yeah, I would love to see that improves, because it's, yeah, I just I see not a ton of need for some of the cervical exams that I've witnessed. But again, there's times and places, right? Um, but yeah, I've also just had like a lot of clients tell me like prenatally, like, I'm not going to get a cervical exam. I don't want to know. It's not going to affect any decisions that we're making. Um, and then they'll like text me after and be like, oh, I'm 1 centimeter, da 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 da. And I'm like, so what happened? Like, did you, I mean, if you want to know, that's fine. That's fine. But like, did you feel like you couldn't say no? Like, because that's a problem too. And I've struggled with that. Like, if you feel like you can't say no just because they're your doctor, like
right.
that's an issue. You can be like, oh, well, if they're like, okay, like, go ahead and change the doctor will be in a minute. You just don't take your pants off. Like, it's fine. You don't have to get a cervical exam that day. It's not gonna, it's just a normal appointment. It's not gonna affect your decisions. So, you know.
Yeah,
I feel like we could talk about so much forever.
we could. We could.
I'm gonna wrap it up, but I'm sure I'll have you back on sometime because I really love like having, like I said, I talk obviously from like a doula perspective, but I love having the medical perspective, talking to an OB, um, because I also think that it's important to have these conversations and for the listeners to hear it because they hear me say all the time some of the things that you said and they're like, oh, okay, now an OB's saying it. So Liz did know what she was talking about. But before we wrap up, I would love for you to share where people could find and follow you. And I will link it in the show notes as well.
Awesome. Well, thank you for inviting me. It's been a great conversation. I've really been enjoying talking with you. Um, so I'm Dr. K, pregnancy specialist. I'm on Instagram with that username, TikTok, Facebook, and YouTube.
Awesome. Cool. I will link it all in the show notes, and I'm really excited for our listeners to hear this episode. So thank you again so much for coming on.
Thank you.